Dean Raska, thank you so much for those kind words. I want to thank all of you for welcoming me here to Oklahoma. This is actually my first trip ever to Oklahoma, so I'm very excited to be in the state. Thank you. But I certainly hope it won't be the last, and I have, long before coming here, heard great things about the work that is happening at the Health Sciences Center and at the university, so I'm very glad to be here. And I'm particularly glad to be here to talk about a topic, prescription opioids, which has been a concern for Oklahoma, but also for the entire country. And there is some great work happening right here in Oklahoma, which I'm eager to learn more about, eager to talk about, and eager to share with the rest of the country. Before I begin, I just wanted to also thank, in particular, the Brandt family. As I was telling them earlier today, each and every day when I walk into the office, I actually pass a picture of Assistant Secretary Brandt, which is hanging on the wall. And it's a reminder of his extraordinary service that he provided to the entire country at a very, very important time in our history, when HIV was just coming on the horizon and we were just understanding what it was and how to deal with it. His contributions go well beyond HIV, but it's a particular honor to be here on a lectureship that's named after him, given all of his great contributions. We got here to this point where we are with regard to prescription opioids and this epidemic over years. This didn't happen overnight. And I was thinking about this in particular when I began my job as Surgeon General, because when I left Boston, when I left Brigham and Women's Hospital to come here, I had a group of nurses who I had worked with very closely over the years, and nurses I had known since I was an intern. And they were the nurses who helped me figure out things when I was on day 2 or 3 of internship and had no idea what I was doing. Some of you know what that's like. They were also the nurses who helped me out in the intensive care unit when I would get called in the middle of the night on the second month of internship and a patient was coding and I had to figure out what to do. And they were fortunately experienced and wise nurses who were with me, who could help guide me. So I got together with them before leaving the Brigham for the last time. And we were just exchanging memories. And one of the things they said to me at the very end is they said, Vivek, if you can just do one thing during your time as Surgeon General, please do something about the drug crisis in America, because it's tearing our communities apart. And I haven't forgotten that, because they spoke based on decades of experience, seeing what the opioid crisis has done to communities in Boston. And I saw that also as a healthcare provider. When I was practicing medicine in Boston, I, like many of you, spent so many difficult moments at a patient's bedside trying to decide how best to reduce their pain without putting them at risk for a deadly addiction by prescribing opioids. And striking that balance when you have very little time with patients, compounded by very little training in how to deal with pain, that is a recipe for disaster. And what we've seen over the last few decades is that we've had a confluence of factors that have come together, an increased emphasis on treating pain, recognizing that there have been times where we have undertreated pain, and there still continue to be populations where we don't do as good a job treating pain as we should. But we also know that the push to treat pain was not accompanied by nearly enough training and support for clinicians. And it was also accompanied by heavy marketing of opioid medications to doctors and to other prescribers. And this was a setup for the situation that we have now, which is we've seen a rapid escalation in the amount of prescription opioids that are written for and that are also misused. We've seen near quadrupling in the number of overdose-related deaths since 1999. And Oklahoma has shared a heavy burden of this. We know that Oklahoma ranks among the highest in the nation when it comes to overdose deaths. But there's a silver lining here, because people have started to pull together to fashion solutions. And Oklahoma is one of the states that is doing that and working hard to do that. And that's why I'm honored to be here with people who are at the forefront of that fight here in Oklahoma. And we're going to have a great conversation in the next few minutes. But in order to really overcome and address this epidemic, there are some key things that we have to do. We have to first change our prescribing practices, recognizing that we've had a dramatic increase in the number of opioid prescriptions over the last 10 to 15 years, where now we in fact have nearly 250 million prescriptions for opioids in the most recent year tabulated, which is more than enough to give a script to every adult in America. You know, we are about 5% of the world's population, but we use somewhere between 75 to 80% of the world's opioids. So there's a massive discrepancy here. So changing prescribing practices is important. But what we have to do in that process is make sure that people who need opioids are not having them taken away. We have to make sure we're treating pain appropriately but safely. Second big thing we have to do is to make sure that we are increasing access to naloxone. One of the great things about this job is the opportunity to go to different communities and see what people are doing, to hear their challenges and experiences. And I've heard more and more communities which are getting naloxone into the hands of first responders, which are making naloxone available even more broadly to patients and family members. These are efforts that are being taken up right here in Oklahoma, and I know you've been a leader in that area. But these efforts are important because they are actually saving lives. The third big thing we have to do is ensure more people can get the treatment that they need. And this is a complicated issue because it's partly about resources. It's partly about training enough prescribers and others to be able to dispense medication-assisted treatment. But it's also about changing how people think about addiction. And that brings me to the fourth issue that we have to change, which is attitudes. If you went into a community and said, you know, we want to build a new cancer treatment center in your neighborhood, we want to build a new heart disease treatment center, we want to build a new diabetes treatment center, very few communities would actually object to that. But if you go to a community and say, you know, we have plans to build a medication-assisted treatment facility here, you hear a different kind of response. And that's because we look at addiction differently than we look at other chronic diseases. And unless we change that, it's going to be hard for us to move forward on the treatment and the other changes that we need in our healthcare system. So changing attitudes is as important in this as changing the system and structures through which care is delivered. But the fifth and final piece is that we have to also focus on public education. We have to help people know that prescription opioids, while they can help in some circumstances, they are highly addictive and they can harm. We have to help people understand that there are things that they can do to actually protect themselves and their families, such as disposing of unused opioids, locking up opioids that are currently being used, and not sharing opioids with friends and family members, even with the best of intentions. Because as we have seen time and time again with the opioid epidemic, good intentions can lead to bad results. So intentions are not enough. You know, I know that even our community of prescribers, we're not always taught the right things about opioids. I remember being taught when I was in training that if you give opioids to a patient who has legitimate pain, they won't get addicted. It's not addictive for them. Now we know that that's not quite the case. In fact, it's absolutely not the case. But that is what so many of us were taught in our training. And I'll tell you that just about a month or so ago, I was in Jacksonville visiting a colleague who happens to be a physician as well. And I sat down and was telling him a little bit about some of our efforts, and I said, can you believe that this is what we were taught in medical school? And he put down his fork at the dining table, he looked up to me, he said, you mean that's not true? And this is a very educated, very thoughtful, smart, and caring physician. So there are many people who still don't know. So these are 5 big things that we have to do: change prescribing practices, increase access to treatment, get naloxone in the hands of more people, focus on public education, and change how our country thinks about addiction so they see it so that we all see it collectively as a chronic illness that we have to treat with the same urgency, the same compassion, the same skill as we would treat any other illness like diabetes or heart disease. Now, we are investing a lot on this issue. You've probably seen a lot more news coverage about the opioid epidemic than you saw 5 years ago. You've probably seen more stories. I know the Oklahoman has written a lot. I just learned several hundred stories about the epidemic, and I thank you for that coverage, because we have to get these stories out about people who are impacted by the epidemic. We have to make it okay to talk about personal stories, because it's only when we start to talk about it that we can come together to fashion solutions. My office over the next few months will be launching an initiative around opioids that's targeted at prescribers. We want to work with our colleagues in the prescribing professions to help shift our practices so that we can treat pain safely and effectively. And we'll be doing that in part by sending a letter to the over 1 million prescribers of prescription opioids, guiding them towards safer prescribing practices. We will be also going from town to town as part of an opioid tour to meet some of the communities that are hardest hit by this epidemic. And so we can both learn about what they're doing, but also share information and experiences from other communities. And later this fall, I will be issuing the first ever Surgeon General's report on substance use, addiction, and health. Now, many people are surprised to learn that there's never been a Surgeon General's report on this topic before. But Surgeon General's reports are important tools that we have in our country to help draw attention and focus to an issue, but also to help bring together the best available science on a topic. The 1964 report on tobacco was an important part of galvanizing what became a half-century push on reducing tobacco-related disease in America. And thanks to that report and related efforts, we have been able to reduce tobacco use rates, or specifically cigarette rates, from 42%, where they were in 1964, to under 17% today. That's a lot of progress, but it's not enough, because each year we still lose about 500,000 people to tobacco-related disease, so we have more work to do. In the 80s, the Surgeon General's report on HIV, which my predecessor C. Everett Koop published, was an important part of bringing focus and information to HIV at a time where there was a lot of uncertainty and a lot of fear. And this is one such moment where we have, again, an important time and a crisis that we're facing when it comes to opioids. And we want to do everything possible to focus our nation's efforts and resources and attention on tackling this epidemic. So our report will not only bring together the best science around treatment, prevention, and recovery, but it will also be a platform that we can use to help shift how our country thinks about addiction. And that has implications far beyond opioids, but for a range of other substance use disorders that people are dealing with. So that is some of what we are doing. I want to spend the rest of the time for our panel and for Q&As, but I want to tell you in closing just how important it is for communities to be engaged in this effort. There's a lot that the federal government can do, should do, and is doing. You may be aware of the fact that our Department of Health and Human Services in the federal government has been supporting efforts to change prescribing practices by issuing most recently the CDC prescriber guidelines and by funding prescription drug monitoring programs. You might be aware that HHS has also been involved in funding programs to increase access to naloxone in states and on funding medication-assisted treatment programs. In fact, just a couple of months ago, I went to Baltimore to announce $94 million in grant money that the Health Resources and Services Administration, HRSA, is providing to expand access to medication-assisted treatment. And that's not all. President Obama has in fact requested over $1 billion in new money in his new budget to fund efforts to target opioid addiction. And many of these efforts are going to expand medication-assisted treatment. So this is the beginning, certainly not the end of what we are doing, but communities are essential here because we know that when it comes to changing attitudes and practices, that no one is more important than communities of practitioners on the ground, than local health departments, than community institutions like faith organizations, employers, schools, and hospitals, which have a major influence on how people think about addiction and how they also practice when it comes to treating pain. And that's why the role that all of you play in addressing the opioid epidemic could not be more important. And that's why I'm here, is because in order to solve this problem, we will need your help, we will need your partnership. And if we have that, if we work together to solve this problem, then I believe that this is an epidemic that we can overcome and that we can make significant progress on in the next few years, just as we have made in small communities across the country. So with that, I want to thank you again for having me here. I'm going to have a discussion here with our panel where I have some questions that I'm going to frame for them, and then we're going to open it up for Q&A for the group. And this is, I realize, a bit of an unusual way to do grand rounds. I've sat in many grand rounds over the years, as I'm sure you have. And usually it's somebody giving a lecture with a few minutes for Q&A at the end. The reason I wanted to do this differently is because this is an important opportunity for us to bring together a range of expertise and opinions. I can talk for hours about opioids, and I'm sure that people would be at rapt attention for all those hours. You would not. I would probably fall asleep in the middle. But what's especially important at this time is for us to marshal our resources across sectors. We are not going to solve this problem one person at a time or with one sector alone acting. And that's why I'm very excited to have the opportunity for the panel here to share their experiences with you and then to talk about how we get over some of the remaining challenges that we have right here in Oklahoma. So let me take a seat here, and then we're going to open up with a few questions. So you've heard the backgrounds of the folks who are here on the panel. We have a lot of experience and perspectives here, so we're going to dig in. Before we do, I have a question actually for all of you. And just by show of hands, I want to know how many people in the audience here feel like you have a pretty good handle on the opioid epidemic, a sense of how bad it is and how it's affecting Oklahoma, just by show of hands. Okay, so a small minority, maybe about a fifth to a quarter. So what I'm going to do is I'm actually going to start with Secretary Klein and ask you if you can give us a sense of a global picture of, or I should say a statewide picture, of how the epidemic is impacting Oklahoma. We know that there are a number of measures that Oklahoma has taken to address this epidemic, but I would love it if you could talk a little bit about what those measures are and which ones do you think are most promising.
Okay, well, thank you very much. So let me start out by saying this is a huge problem in the state of Oklahoma. It's actually comforting to me to know that there are as many people as there are in the room who are familiar with that challenge that we're facing. Since 2007, we've lost 5,300 lives, unintentional poisonings, and 80% of those unintentional poisonings are actually prescription drugs. And then if you drill down into those prescription drugs, 90% of those are opioids. So you start to do the math and you start to follow the logic, and you also look at the increased number of prescriptions that have been written in the state of Oklahoma, which parallels exactly the increase in the number of deaths. It provides an incredible opportunity for us. So as you've mentioned, there's a multi-pronged approach that's really needed. So we look at multiple measures and really responding to that. Some of those measures, I'm being prompted to speak up a little bit there, so I'll do that. Thank you. So we look at deaths as really the biggest measure that we have available to us. Because of the prescription drug monitoring program, which is now available in the state of Oklahoma, we have a lot more data. And that data actually helps inform not just people sitting here, but also helps inform the providers. So you would have a better sense as a prescriber about whether you're an outlier or not. So we might have the same specialty, but if my prescriptions are running at about twice the rate as yours, even though we have the same specialty, there's a good chance that's a problem and needs to be looked at. So that information is now available for licensing boards and others. We're looking at the use of naloxone. I think Commissioner White will say a little bit more about that, but a multi-pronged approach there. So what can we do on the front end around education, whether it's for the prescriber or for the community? If we have people who are actually experiencing overdoses, which of course we would obviously prefer to avoid, but if they do, then naloxone is absolutely a tool that needs to be available for people to reverse that overdose. We've seen, as you mentioned, as we heard from Dean Raskob, really looking at the evidence. The evidence is there, and it needs to be in the hands not just of providers, but family members and friends as well to help reverse those. And in those situations, that can be life-saving. We can then get people into treatment if that treatment is available. So we're looking at all of those different data points.
Mm-hmm. Okay, thank you. Thank you. I'm actually going to turn to Commissioner White for a moment, and would love for you to comment a little bit on the naloxone piece, but more broadly, would love for you to start and talk to us a little bit about the overlap between substance use and mental health and mental illness. I know this is an area that you've worked on, that you've thought a great deal about. Tell us what that intersection looks like in Oklahoma, and what are some ways that we can work on addressing both?
So many of you have heard me speak before, but I think this is one of the most important questions, and that is the fact of reminding us that these are brain diseases. Just like diabetes being a disease of the pancreas, these are diseases like any other disease, and I appreciate your comments reiterating that for Oklahoma. Hopefully Oklahomans will hear it from a different voice, because I think I've been pretty loud about it, but we haven't quite gotten there yet. So I think reminding people that just like diabetes affects the pancreas, mental illness and addiction are diseases of the brain, and they often go hand in hand because it's that same organ in the body. Depending on the statistics that you look at, between half and 3/4 of all people who struggle with both. So it's very common. When we look at what we're dealing with in terms of prescription drug abuse in Oklahoma, it's 5% of our population over the age of 12. So if you take everybody in Oklahoma 12 and older, 5% of our population is struggling with misuse and abuse of prescription drugs. So looking around the room, it doesn't appear that there's anybody under 12 in the room today. So just quick eyeballing, I mean, not to insult anybody, all of you look very young, but just quick eyeballing, just basically if there's 300 people in the room today, 15 of us are struggling with abuse or misuse, not just have a prescription legitimately, struggling with abuse or misuse in this room today. So now think about our population across the state. This is a significant issue facing Oklahoma. The good news is we are making some steps, but we have to step faster. Our rate has actually, there were only 19 states whose rate of overdose death went down between 2013 and 2014. Ours was one because of the initiatives of all of us working together, and I think that's important for folks to understand is how well we do work together, partly because we have to, because we're poor in Oklahoma. We are not a well-funded healthcare system, so we all have to work together. The health department, mental health and substance abuse, and our Medicaid agency, our director here, Nico Gomez, all working together on this issue along with so many other folks. And as we work on this issue, even though we're going down in one of those 19 states, we still have the 10th highest rate of overdose death in the United States, even going down. So it's a significant issue. One of the things that we're focused on, as Secretary Klein mentioned, is naloxone. One of the things I think we can be really proud of is we have saved 75 lives across the state of Oklahoma as a result of our naloxone initiative. 75 Oklahomans, basically within a little over 12 months. When you look at that, that's a partnership between our two agencies, EMSA, funded through the health department, and law enforcement funded through the Department of Mental Health and Substance Abuse Services. 42 and 33 lives saved together. That's progress. That's 75 Oklahomans who wouldn't be here with us today. But there's so much more to do. I could keep talking, so I think I've answered your question initially, but hopefully you'll ask more about some other initiatives.
Sure. And I asked about this in particular because I know that for many of us who are clinicians, we have seen the influence and the impact of mental health on our ability to take care of any issues that patients have. I remember learning very early on when I was training that I could spend all the time in the world adjusting somebody's insulin regimen, coming up with the perfect dosage of their antihypertensives and send them out on what I thought was a perfect set of prescriptions. But if they came in also with severe unaddressed mental health issues and I didn't address those, then their likelihood of following up, as I'd hoped they would, or taking their prescriptions was dramatically impacted. And so I think many of us have recognized that mental health impacts our ability to take care of the rest of someone's health. But because we recognize it doesn't mean that it's easy to actually address, because many clinicians don't have the training to know what to actually do. We also have a real problem with lack of integration of behavioral health treatment with the rest of medical treatment, which makes getting care more fragmented and more difficult. And this is an issue I know, Commissioner White, that you have worked on, is the integration of primary care and behavioral health, which I really applaud you for. I think that's very important. Thank you. Thinking about the clinician role, I want to actually ask a couple questions to Dr. Subera. We know that clinicians, particularly primary care clinicians, are extremely busy in their offices. We also know that they get asked to do more and more and more, often with less and less and less. And I think that you have an exemplary and wonderful career where you have taken it upon yourself to get trained and certified in medication-assisted treatment, and you are providing buprenorphine treatment in rural parts of the state, which is much needed. I know you told me right before this that there are only about 60 people in the state of Oklahoma who are providing MAT, which is an astonishingly small number in a state where there is great need. But the question I have for you is, as a primary care physician, how should people think about those difficult moments where they have 10 minutes with a patient and they recognize there might be an issue that they have to discuss around opioids or a larger substance abuse issue? What advice do you have to give to clinicians about how to navigate those moments and how to figure out how to get somebody help while recognizing they may not always have the training and the time to do so?
Thank you very much. I think I should apologize for my lack of oratory skills. First off, one of the things that I really appreciated when I heard your speech at the National Summit was when you talked about part of your job being to stamp cigarette boxes in the windowless room. I thought, I sit in a windowless room and talk to sick people all day. I think that's the first time I've really felt like someone in government really understood what it's like to be a doctor. And especially in the speech when you talked about how hard it is to talk about some of these difficult decisions with patients. I think if I was to give advice to practicing physicians, it would be to try and maintain an environment of discussion with your patients where this is not a taboo to address. I think a lot of physicians feel like, you just don't want to go there because you might get an answer. And once you get that answer, then that's going to dictate what you have to do or what you should do. And like you mentioned previously, we have around 17,000 people registered to prescribe controlled substances in Oklahoma. We have about 120 who have gone through the waiver process to learn how to prescribe buprenorphine. And only about half of those people are actually using their certificate. And so we have a population of 3.6 million people or thereabout, and only 60 people prescribing buprenorphine. I think one of the most important things physicians can do to address this problem is to get trained to provide MAT. And I know Commissioner White and Secretary Klein and myself and the state medical associations have been working to put on an event later in the summer, and I hope that's going to happen. And hopefully we can double or triple, or who knows what we can do with the number of people that are able to prescribe this needed medication.
Just a follow-up to that, I think what you said is very important, which is that we do need more clinicians who are trained in providing medication-assisted treatment. But I will say for many clinicians, when I talk to them, the prospect of doing MAT is scary, especially if they're not familiar with the training, they're not used to it. It seems onerous, it seems difficult, it seems complicated. Can you shed a little light for the clinicians who are here on what that process is like of getting trained?
Higher. Well, personally, I think prescribing MAT and buprenorphine in the office has been one of the most rewarding parts of my practice. When you're in primary care, you're going to spend a lot of time in that room talking with sick people, a lot of unhappy people a lot of the times, trying to make things better for them, and you don't really get any of those exciting, life-changing events like you see when you watch ER on television or something like that. But when you can take a patient that's totally broken down and in the throes of withdrawal in the space of 3 to 4 hours, turn their life around, it's really amazing. And then to see them, move out of their parents' house, get a job, buy a car, do all these things that life is really about. It's really an amazing feeling. I've tried to expand interest in it among my colleagues, and I think there are barriers there. For instance, there's no insurance code to bill for the induction visit, which is difficult. We also practice in a very time-restricted environment where we have all these quality parameters for various disease processes that we're expected to address, and now a lot of prescribers, I think, look at it as, do I really want to add another service line to my practice? Can I afford to do it? And I don't think we can afford not to do it. And also, there's probably a little bit of a problem with the stigma that remains attached to people that have an addiction or a substance use disorder. I've had friends say, well, I don't really know if I want those people in my waiting room. And they say, they look a lot like you and me. And when I first started prescribing buprenorphine, it was pretty much all prescription opioid problems. But I would say over the last 3 to 5 years, heroin is becoming a much more common complaint when patients present. I think out of my last 5 starts, 3 have had heroin experience. And I remember my first heroin patient was a school teacher, and I think she looked a lot like you and me. So.
Absolutely. Thank you for that. I just have to sign that our time is starting to run short, so I want to make sure we have time for Q&A, and I want to get in some thoughts from Ms. Fry as well. Ms. Fry, you have been an incredibly vocal advocate on this issue, which I thank you for, and we need more advocates like you. What I was hoping you could share with the folks here today is two things. One, a little bit about what inspired you to take on this issue. But second, since you have an opportunity to share advice with clinicians who are caring for patients every day, what advice would you give to clinicians who are dealing with substance use and addiction, sometimes knowing it, sometimes not knowing it, and wondering how they can be of help to patients?
Thank you so much. It's such an honor to be here today. I often joke and tell people that I am the editor of the Oklahoman, and sometimes that makes people a little nervous. But the one you should really be nervous about is the angry mother. I got into this passion of mine to try and make a difference because my son, who is 30 years old now, he has been in and out of treatment for the last decade. Lots of treatment. He started at a really young age, just at a family wedding, like so many people do. He sneak around the room and I'll have a sip and I'll have a sip. And one thing led to another, and he did break his wrist at one point in time, and he took his own cast off. And that was such a huge red flag to me that he was a serious drug seeker. Now, fortunately, that doctor did not fall for that, and I applaud him for that. But it happened so quickly, and he went from one stage to the next to shooting heroin, buying heroin in South Oklahoma City. So when your child is diagnosed with cancer or something that's very public, people bring you casseroles. They would immediately say, "How's your son?" But what I noticed is people were not saying that to me. They weren't saying, "How's your son?" even just in a routine update way, and that made me mad. Because my son was sick. He had a disease just like cancer or anything else. He had a disease of the brain, and I needed support. So about 4 years ago, I wrote my personal story, and I put it on the front page of the Sunday Oklahoman. But something really happened after that time. People would come to me everywhere I was. If I was at a black tie event at Cowboy Hall of Fame or at Walmart picking out vegetables, people would touch me on the shoulder, and they would whisper and say, "That's my story too." So too much shame, too much stigma is associated to this disease. And that's why I like to get loud about it at every opportunity and to anyone who will listen, because we have to talk about it, because talk can bring about change. As for the second part of your question on what doctors can do, you know, I'm so excited that Oklahoma did finally pass the PMP, because I think that will help. But just being alert, because an addict can lie better than anyone in the world. It just goes along with the disease, that ability to manipulate. So the more doctors can be curious and the more questions they can ask and the more information they can arm themselves with, it can make such a difference. Sometimes an early intervention, I know, can make a difference in getting a person the help they need. More access. I mean, I really applaud you, Dr. Sabera, for encouraging doctors to do that. My son lives in Colorado, and he drives 4 hours once a month for a Suboxone appointment. So that's another barrier. So if we can remove some of these barriers and educate the public and educate the medical doctors, I know we can get a handle on this epidemic and make some changes.
Thank you, Ms. Fry. You know, I was just, when you were talking, I was just thinking it's so brave of you to share your story. But the second thought I had was, I hope that there will come a day where we won't have to describe that as brave. It will be routine for people to be able to share their stories around substance use. So thank you for that. I want to open it up now to questions from the audience. Go ahead, sir. We have I think we have some mics that'll be brought to you as well. So just give us a moment to get you the mic.
Hi, Dr. Bill Banner. I'm a medical toxicologist, and I'm the medical director for the Oklahoma Poison Control Center. I'm also happen to be the president-elect this year of the American Association of Poison Control Centers, which is based in Alexandria. We are very much involved in this, and the NPDS data that you refer to comes from the 50 poison centers, 50-plus poison centers in the United States. We're the contributing this data. We get all these calls about the naloxone program, We feel like it needs to be monitored very carefully. It's promoted. We've been very solidly promoting it, but we would be glad to meet with anybody and everybody at the Surgeon General's level to try to get more involved in monitoring this program. All of these things have ramifications. Every one of you has said something that struck me. Prescribing physicians, the medical directors of poison control centers are largely medical toxicologists, and the American College of Medical Toxicologists has a lot of members in addiction medicine. The naloxone program, we're getting the calls about pulmonary edema following reversal. We're very concerned about that. We hear stories about the Prince-like events where it's used and then nobody goes further and pushes those patients into getting treatment. So one of the downsides of using it is that people will not get the treatment that they need. We need to get them to the hospital after we reverse them at the scene with naloxone. And the poison centers help push that agenda. So we're very interested and want to very much be involved at collecting data, following up, and helping protocolize this. And we're ready to help you in any way. But some side issues. Buprenorphine in the home is great. Now we have treatment protocols for children that ingest their parents' buprenorphine. So there's lots of prevention issues that have to get involved. So we're involved at all the different levels that you're talking about. And we accumulate RADAR's data, which you're probably familiar with, and NPDS databases. Those are all from poison centers. And so we're very supportive of what you're doing and would very much be glad to help you.
Well, thank you so much for offering that. I want to point out that my Director for External Engagement, Siobhan Arline Bradley, is here, and we'd be happy to connect with you and see how we can engage you on the effort. Thank you so much. Other questions? Go ahead, ma'am, right here.
Dr. Murthy, can you hear me?
Yep, we can hear you.
Thank you. Rachel Franklin, Family Medicine. I'm the medical director for the Family Medicine Center clinics. We see about 50,000 patients a year, 60% of whom are Medicaid. And we have developed a chronic pain curricular process for our residents in family medicine, one of whom's right here. I wanted to give you a little bit of perspective, if I could, on the naloxone from a prescribing background. We have been piloting a little bit the prescribing of naloxone along with the careful education of patients and the need to call 911. And we've not yet had a single patient refuse to fill it. As a matter of fact, Medicaid is paying for it 100%. Medicare Parts A and B are covering it. The Part D plans are covering it. We've had a very good outcome. What we're trying to do is exactly what you were talking about, and I greatly appreciate your balanced approach. We're trying to keep the pendulum from swinging all the way back to where we tell people to, excuse the language, suck it up. Because people do hurt. And we're hoping that by training the new generation of primary care docs, you'll have less to deal with, Dr. Sabera, I hope. And again, I would like to meet with you to talk about what we can do to help as well.
Really appreciate you sharing that. That is very helpful. I think the point you raised about the pendulum is very important, because you're right, we don't want to swing in the other direction. To maintain, though, a balance, I think will require us not only to train our next generation and current generation of providers in how to treat pain, but I think we also need to invest more in non-opioid treatments for pain. We know right now that there are other things that can be helpful for reducing pain, from physical therapy to cognitive behavioral therapy to, in some cases, certain types of meditation have been proven to be effective. There's a range of treatments, but what we need to do is to keep investing actually in the research to help broaden our arsenal of tools that we have to treat pain, and then to help people understand how to actually access those. Because we recognize that with all of the non-opioid alternatives to pain, some of them are fairly easy to access, but not all of them are. And so we have to both work on research to discover what's in our toolbox and expand that toolbox to make the tools also more easily accessible. So appreciate your comments. Thank you. Okay, well, I think we have time for 2 more questions. Go ahead, sir, right over there.
Thank you.
Right here.
Okay, why don't we do you first, and then we'll take our last question there. Yeah.
Okay. My question's for the Surgeon General. My name's Tiffany. I work at the Department of Mental Health and Substance Abuse Services and Prevention. I work on the Partnership for Success grant, which deals with opioid use. I go to a lot of coalition meetings, and at one of them, Gail Box was there. Her son's Austin Box, who is a well-known football player here who died of an opioid overdose. One of the concerns that she brought up is the Clinton Foundation has now made the naloxone available to all public high schools in the nation, and some educators are hesitant to accept that for a number of reasons, but one of them is because they feel that it gives people permission to use opioids. And I'm just curious, if you were standing in front of one of those educators and you only had maybe like a minute to talk to them, how would you respond to that to convince them of the importance of naloxone and not to be afraid of it?
To not be afraid of naloxone or opioids? Which one?
How not to be afraid of naloxone. They seem to be afraid of naloxone because it's like, well, if we say that we have a supply of naloxone, our students will think, well, hey, we can go use opioids because we know that we'll be safe.
So that's a really good question, and I think there's a simple analogy I sometimes share with people, which is if you had a child who had an allergy to peanuts, would you hesitate to ensure that there was an EpiPen around? You wouldn't. You wouldn't say, well, if we give that child an EpiPen, he's going to just go and find all the peanuts he can and consume them. So I think have to help people understand that this is similar to many other illnesses that we think about, and prevention is key here as well. And it turns out naloxone is scientifically one of the most effective tools we have to prevent overdose. And so we should make sure that it's available for anyone at risk. So, I think it's important to help people put this in context. I know that new medications, especially things that have to do with substance use disorders, are scary. Sometimes to families who, with the best of intentions, don't want to put their children or their family members at additional risk. But what we have seen now, time and time again around the country, is when we expand access to naloxone, it saves lives, hands down. And that's why we have to make sure that it's available for children and adults alike and anyone who needs it. All right. One last question we'll take from over here.
Thank you for your presentation. I'm Dr. Jacob Henderson. I'm a postdoc here at the university. And one thing that you talked about at the beginning was the importance of being able to communicate with physicians about these important issues. But even besides just physicians, it's also important to be able to talk to policymakers, the media, the general public. I don't know if you watched Last Week Tonight, but John Oliver actually had a very fantastic episode about this very topic last week, about scientific literacy and how there's been a real problem among researchers of actually communicating what they're learning, and it's creating all this confusion, and that's why people like your friend don't know what's really out there, and a lot of it's because of how we as scientists have failed to communicate that. So just in your opinion, what are ways that we can do better, whether you make a career as a policy specialist or even just as a researcher, how can we better get our message out there to people?
This is such a good question. I'm so happy you asked that. I'm trying to control myself from going on a soapbox about this. I'll just say that my belief is that every healthcare professional should be trained in communication skills, because we are living in a worrisome time where people are distrustful of science. They're distrustful of what they might perceive of as intellectualism, because they feel that it may not provide the full respect or understanding of the range of views that's out there. But in the absence of having strong voices that can help people understand what science is and what it tells us, then I worry that we are only increasingly going to find ourselves in these debates where we are giving equal value to both scientific and non-scientific perspectives. And while we should listen to everyone and to their opinion, You know, I can look at this and tell you that there is water in this bottle. And if somebody tells you, no, this is Coke, that's not two different perspectives. There's a right answer and there's a wrong answer, right? And the right answer is that there's water in this bottle. But the false equivalency that is sometimes afforded to scientific and non-scientific perspectives is very worrisome to me. And the question is, who's going to change that? Well, I think it has to be people like all of us who are trained in science, who understand science, who also see how science is translated into health and into benefiting people's lives. You have so much credibility when you go out there and you talk to people about your experiences and about what science tells us. But you know, I'll tell you that before I was Surgeon General, I spent many years working on organizing physicians to talk to communities and to talk to policymakers about health and about what we need in our healthcare system to better take care of our patients. And what was striking to me is that many of the clinicians I worked with felt that nobody really wanted to hear what they had to say. But the truth is, people really do. I had one member of Congress who told me, in fact, he said, you know, we get calls from constituents all the time. But if a doctor calls us, that's listed as a notable event. He said, if 10 doctors were to call us on one day, that's a full-blown crisis. Now, 10 is not a lot of calls, but it just goes to show you how infrequently people hear from clinicians, whether they're policymakers or whether they're members of the public. So I wholeheartedly agree with you. And I would love to see not only our training programs incorporate more communication skills into the training that they provide, but I'd also love to see our professional societies make this part of how we think about our larger responsibility as clinicians. Because if we only focus on what we're doing in our clinics, we will be able to achieve some change, but not nearly the amount of change that we have to create. And I'll just say in closing, since I know we are out of time, that, you know, first I just want to thank all of you for being here, for more importantly the incredible work that you are doing in Oklahoma to address the opioid epidemic and to make sure that Oklahomans are safe and healthy. I know we have more work to do, but it is reassuring to me that we have leaders like you who are working so hard on this cause. But I also just want to say that this is a pivotal moment for both our country and our professions. I say that because when we look back in 20 or 30 years on this time, we will see an epidemic that was in the process of exploding. And we and our children and the people around us will ask us, what did you do? You were there. What did you do to address this epidemic? And I want to be able to tell them that even though we were busy in our clinics, even though we may not have been trained in how to communicate with the public or how to take on new challenges like treating pain or in thinking about how to advocate for the solutions our patients need, that we came together, we helped each other, and we found ways to do what needed to be done to address the opioid epidemic. That's what I want us to be able to tell our colleagues, our kids, and our families in 10, 20, 30 years down the line. And I do believe that this will be one of those moments that's really pivotal. So that's why I especially appreciate all of you being here today. I know that you've heard about the opioid epidemic. I hope now after the discussion that we've had that you have even more insight on how serious it is, but also on the kind of things that we can do as clinicians and as a community to address the epidemic. But I just want to lastly say that this is not the end of our conversation, that we know that to really address this epidemic will take community engagement and also sharing of lessons so that we understand and can learn from each other. Because that ultimately is what's going to help us in the long run, because there are a lot of good ideas out there. Implementing those ideas is a whole other ball of wax. And the people who have knowledge and understanding of the science of implementation are the folks here who are on the panel, many of you in the audience, and people who are rolling their sleeves up in communities to address the epidemic. That doesn't mean that I'm talking solely about people who are providing treatment, who are passing policy. I'm talking about moms and dads who are thinking through how to have these difficult conversations with their kids. I'm talking about teachers who might find prescription opioids, like in the classroom, in someone's bag, and think about how to have a conversation that will actually lead that child to seek help. I'm talking about employers who suspect or worry that one of their employees has a problem and is thinking about how to have that conversation and get them the help they need. This is the kind of learning that we need to share. That's the kind of community-based work that's going to help us turn the tide on the opioid epidemic. And that's actually why as we launch our campaign, we actually are using the hashtag Turn the Tide, because we do believe that this is a moment where we can build a movement to help change the dynamics that are at play and ultimately turn the tide on the opioid epidemic. So I want to thank you again all for being here and for welcoming me. I really appreciate it and certainly hope to see all of you again soon. Thanks, everyone.